Hello, everyone. Please welcome Professor Ashutosh Sabharwal, who is the second keynote speaker for today, IoT Day. I'm going to give a very long introduction because I feel like I cannot miss anything. These are important, right? So, Professor Sabharwal, sorry, works in two independent research directions. One is, and both of them are making really strong impact in the field in wireless communications or wireless networks and digital health. So his ongoing work in wireless focus on the joint wireless communication and imaging and large-scale experimental platform. And he is a co-inventor of full duplex wireless, which has been adopted in many communication standards. He also led WARP and Renew platform initiated, and on behalf of the student who was written our thesis using the WARP platform, we really appreciate Ashu's contribution to the community, especially in this area. Right? In the digital health research, Ashu leads the RISE Digital Health Initiative and is co-director of the Methodist RISE Digital Health Institute. His digital health research focus on development devices and data science to quantify behavior biology pathways across many diseases. Right? And today, he's going to give a talk related to digital health research direction. And without any further delay, please welcome Ashu, everyone.
Good morning. First of all, thanks for the invite, Wei. I appreciate it. And great to see some of the old friends and make some new friends today. So I'm going to talk about the digital health research today. I don't have very deep lessons, but mostly a personal story in this. And as a VP said, I work in two areas, working in wireless for many years. Around 2009, I got into health, and this is journey starting 2009. So broadly speaking, in healthcare, innovations are plentiful. Actually, there are tons of conferences across different areas. In bioengineering, if you go, tons of conferences. The number of publications which come out in health-related area, biosciences and others, is huge. It's a massive area. NIH, as a funding agency, is also funds a lot of research and is responsible for many breakthroughs. But what we know for sure is healthcare adoption is a very slow process because healthcare is actually a risk-averse customer for good reasons, actually. So what I will share today is some of the personal journey, as I said, and where you will realize all the things which Martin also talked about are really crucial. Innovation relies on reductive thinking. You have to take some blob of a problem, find the core element in it where you can innovate. Then if you want to convert them into products, that requires systems thinking. Martin also talked about it earlier in the morning. And eventually, adoption, which is the slowest part in healthcare, requires evidence, which you can only build through partnership. So I've picked 3 examples for things I've done over the years. And I'm going to talk about where we are in some of those examples. So lung health is what I got started as the first project. Those we are at a stage where not only products are out, we are now in scaling stages. So I'll talk about that story first. In diabetes management, which is something I started later, I would say the innovation and the product are, we have already have first version of them, and I'm going to talk about adoption and that. And mental health also I've worked very long, but mental health being a very slow area to make a change, I would say I'm still working on the product market fit before we can think of what product to build. Okay, so earlier on when I got started, very quickly I realized that human behavior is something which is under, every doctor you will talk to will eventually end up, my patients don't do X, my patients don't do Y. Right? And in the end, essentially what they're talking about is human behavior has a huge impact on human health, and that's something is well understood to the point that we actually, there are definitions and many taxonomies on it. What is human behavior is pretty much anything we do during our daytime, during our life. Could be voluntary actions, could be involuntary actions. They evolve over time, they are context dependent, and they are both individual and social behaviors. For health and health behaviors, there are essentially many parts of this behavior, right? There are personal behaviors. You're part of an organization that might actually impose certain behaviors on you. You have environmental behaviors based on where you live and what your cultural heritage might be, or what your family values might be. And then policies actually impose new types of behaviors. Okay. Now, why should we care about human behaviors? We actually know quite a bit, right? So smoking causes pulmonary illness. Smoking as a behavior causes an illness. Poor dietary control causes increased risk of cardiovascular diseases. It's actually, we hear about good diet all the time, and social contexts are responsible for addictions. So there are a lot of, teenagers, for example, will get into addictive behaviors, often through a social impact, okay? Now, what we want to do is also try to understand why measuring behavior is really crucial, right? So I talked about that the human behavior has an impact on human condition. And if we when we think of medicine, medicine is often a pharmaceutical intervention. So here's an example of an inhaler. Inhaler is actually often a steroid. So steroid is given, if I'm not feeling well and I take steroid, is to improve my current condition, my current biology, right? So, but inhaler use behaviors, how often I use behavior, how do I use my inhaler correctly, have a direct impact on overall outcome, on my asthma control. So, for example, regular and correct use of inhaler is important. And so we have to learn actually how to understand human behavior, or essentially in this case, in this example, inhaler use behavior. So if we do not actually have quantitative measures of behavior, then we cannot find quantitative behavior health relationships, and that makes it actually harder to design behavioral interventions. So measurement of behavior, then we'll keep coming back to the theme. We need to be able to measure, quantify behaviors, different behaviors in certain form. Okay. So essentially that became the central focus. That particular behavior biology connection for me has been a central focus for almost everything I do. It just manifests itself in different problems differently. So over the years, there are different things, and in fact this chart is growing for me very rapidly these days. I worked with pediatrics, I worked in diabetes, which I still do. Pulmonology was the first thing we do. That we spun off as companies, has multiple products now, and most of the innovation now happens through company for me. And then mental health is, I would say, still somehow in science and soon to be practice domain, right? So there are different things. Nowadays I work in cardiology, in infectious diseases, and so on and so forth. And hopefully I'll talk about those in a later workshop. So what I'll do today is talk about these three things, and in each of these cases, essentially as I go through the cases, what the types of behaviors we are talking about, and especially behavioral interventions to do, actually will become harder. The behavior will become less easy, increasingly harder to quantify or even define, and as a result, they also become harder to intervene on. Okay. All right, so let me talk about pulmonology. So the first thing I got started in 2009, 2010 timeframe. In fact, my first PhD student, when she walked in and said, "I'll work with you, Ashu," and I told her, I have no idea what I'm about to do. And she said, "That's fine with me." So she was one of the bravest PhD students any faculty member can actually ever have. Okay, so getting started, there are asthma and COPD, which is a chronic obstructive pulmonary disease, often caused due to smoking. It essentially affects around 10% of the population. And essentially, your airways get constricted for different reasons. And one of the most used intervention is an inhaler. Inhalers have different molecules they use depending on what the context is, what the clinical context is. But most of the 40 to 70% of inhalers used today, depending on the disease type or the country, are what are called metered dose inhalers. They look like this. You might have seen people shake it, and then they will inhale and deliver a dose. And it's inhaled through the mouth, so the delivery system is very simple. It's very effective. It's a direct delivery to lungs because you're just inhaling it. As you inhale it, it goes directly to lungs, which is the affected spot. So as a medication delivery mechanism, it's the most effective mechanism. You're not going through bloodstream, and so bloodstream takes longer to actually act. So, and airways essentially directly can respond to medication. That's why there is something called rescue inhaler. If I am having a really difficult time breathing, rescue inhaler, they will deliver a steroid dose within one puff, and often that can act really fast and save people's life, in fact. Okay, so what we know is the regular and correct use of inhalers leads to more of the medication reaching your lungs and better health outcomes. And what we don't know is how to measure these parts, especially correctness of use of inhaler, right? So regularity one can measure if I press it, when I press it. So these things are actually, companies have built those kind of things, but how do you measure correctness of use of inhalers? Then from there on, we have to figure out how much medication actually reaches the lungs if I use it incorrectly or in certain form. And then once I have a certain deposition, if I don't have full deposition, how much health improvement I can get. Now, to appreciate why this is actually a non-trivial problem, most things in biology are highly non-linear. We don't know how they act. They are all and they're very person-dependent, okay? But let's just think about what is inhaler trying to do. It's actually fighting natural evolution. Our airways are not designed to breathe in any types of fluid. They're designed to breathe in air, okay? Also, there is a 90-degree turn in our tract, right? You have something goes in, and then there is a 90-degree turn to go to lungs. So it's as a pathway to delivery is actually kind of not a very ideal pathway to lungs. So what happens is because of these constraints, especially that there is a 90-degree turn, the best case you can get out of this delivery mechanism, which is inhaler, is 50% of the medication can reach lungs. That's about it, right? Other 50% will get deposited on other parts of your airway before it reaches lungs, okay? And in the worst case, you might only get 5%, okay? So, like if you puff in random places in your mouth with wrong orientation, you maybe even get less than 5%, but 5% is generally what we have measured in patients. So there is a huge gap from 5 to 50% of drugs which can come from correct use of inhalers. Now, why is it inhaler use hard? Is inhaler use, generally the steps come in this form. They say, shake your inhaler, open the cap, breathe out fully. That means you empty out your lungs. Then you have deep, slow inhalation. Then you actuate the inhaler and hold your breath for 10 seconds. That's basically abbreviated version of how the instructions from your doctor would look like. Now, these actually look simple, but what we observed is essentially pretty much everybody makes some mistakes, and actually we have data to show for that, okay? So we first built a system to actually, this is on the top left is a system we built at Rice, which has certain sensors, and that's Rajoshi, who was a PhD student, holding that sense to actually be able to measure orientation, time of actuation, actual flow, at what flow you are breathing in, which was required some innovation. And then you essentially, we can then actually measure out what the patients are doing on each of these stages, okay? And the right two things you saw, those were actually, we had spun out a company, Cognita Labs, and version 1 and version 2 of that product are shown there. So version 2 is what's actually on market now. Okay, so we took this first version, did an IRB approved study. This was done at Baylor College, Bentop Hospital, right across Rice University. So Rice University is across the world's biggest med center, so it's very easy for us to actually find clinical partners. And then an expert who actually measured correct inhaler use, which is the current clinical practice, gold standard, is watching people do it. And then other one is through our sensor-based system. So first of all, for the first time, we got to see recordings of inhaler use. What are people actually doing? By the way, all these 23 patients were real patients who had been using inhaler for at least 1 year. So from clinical use point of view, you can call them expert end users. Okay, so they know how to use inhaler. So these are the things, and what these curves, for example, are flow rate. At what flow rate people are breathing in when they're doing this breath maneuver. So you see very wide shapes of, some people breathe in very hard, you see huge peaks going up, some people take their time to actually breathe, so on and so forth. And it depends on what their lung capacity is. And there is a large variance in peak flows and duration, essentially. So it's really all over the map in these cases. Second thing is errors. 100% of our patients made an error, at least one error according to the guidelines. 60% of these errors were actually missed by observation, which makes sense because any person cannot see what's happening inside your mouth. So as a result, you can't measure flow rate through observation and so on and so forth. And then there was significant discrepancy in what we call flow and timing errors. So one of the key things in inhaler use is you have to start breathing in and then press the inhaler, because you have to create a laminar flow and then let the particles flow over it. The moment you switch this thing, you actually press the inhaler too soon and breathing in later, that's like the worst error one can make, as we actually demonstrated it also, okay? And that's discrepancy is really crucial, is you can't measure it from outside. When did the patient actually start breathing in, okay? So what we did was, we were a little bit more methodical after this set of errors. So Rajoshi actually built this whole setup, and there is a box which you can buy, those blue box called pulmonary waveform generator. It can generate anything, any different types of arbitrary waveform of lung breaths, how lungs behave. Could be deep breaths, could be normal breathing. And then she built a robotic system to actuate things, measure deposition, and so on and so forth. And in this case, this particular part is actually like essentially input to the lung. So it's a collection system. So we can actually see how much of that actually reached the lung. And there is something called Alberta idealized throat. So this is actually the throat here. So it gives you that 90-degree turn, and it's based on lots of measurements. It comes in children's size, adult size, and so on and so forth. Okay, so what did we learn from it? There is a significant drug loss due to single technique error. Okay, and so and the technique error is called coordination error, which is what I just described. When you start breathing in and when you press the inhaler, that delay, whether it could be positive or negative, has the single biggest impact on drug deposition. So if you press the inhaler too soon, which is the minus 0.5 seconds, or then you can have up to 23% loss in your deposition. And the maximum is when you start inhaling, and then you press it after around a second. That means you actually created sufficient laminar flow to do it, okay? So we actually got the quantitative results. It turns out we were surprised that actually there were a lot of literature in the inhaler community. By the way, there is like journals written on this. This is discussed in every conference. There were actually surprisingly very few results on understanding errors in use of inhalers. So the human element which causes error was actually not well understood. So actually some of these results made it to consumer reports. I would say I would never actually have a publication or consumer reports published, took these results, and now they actually put as a guideline in inhaler use. So we thought that was probably the most interesting visibility we got out of this. Okay, so we took these ideas, and that's what the Cognita Labs eventually built. So they have built an actual system which is full of all these different sensors. It's actually much more enhanced, so now it's not just measured, it actually corrects. So it has a visual system, but it also talks to people and essentially corrects your orientation of the inhaler in real time. It gives you an idea, because it can measure flow. As you start to breathe in, it will actually advise you to press the inhaler at the right time. And you can actually, we have used this now, done several studies to show that it can increase deposition to lungs, right? So that part is actually done. This device got FDA approval in 2020, so it's in market. There is a direct-to-consumer market. People can just buy it and put it on their inhalers. For example, many parents buy it for their children, so they can actually make sure that the children are using their inhaler correctly, especially if they are new inhaler users. But what I wanted to quickly talk about is if you want to scale this up, we have to have partnerships. And one of the interesting partnerships we are involved in is with Medicaid population. And Medicaid population is generally for folks who are is a state federal program which is for patients who are generally of lower income status. And we are working with, for example, in this case, Wisconsin Medicaid. So, of course, a very slow process, but it is actually trying to reach people who actually need to be on inhalers, but they actually have troubles either staying on for different reasons. Okay, so that's an ongoing partnership. The company actually also builds another product, which is a measurement product called PulmoScan, also FDA approved. That one is actually a little bit better scaled. It's already in 10 plus countries, has run more than 50,000 tests, reaching almost 100,000 tests very soon. And there our scaling is happening in two different ways. For example, some of the clinical partners are now building programs around it, home monitoring programs around it. And then we are working with one of the largest device and drug manufacturer in India, Cipla, which are building out a very low-cost version of this. So they're trying to reduce the cost 10x. We are actually already very low, and they're going 10x lower, and then they will scale it to distribution in India. Okay. So that's a rapid-fire introduction to what I did for lung health. And the company is actually is right here. It's in Santa Ana. It's not very far from here. They're building 2 more products, which should be coming out. So they will have a whole bunch of new products coming online. Okay. So I'm going to switch gears. I'm going to just keep going down the journey, which is I'm going to talk about diabetes management. Got nothing to do with lung health, a whole different topic. Okay. Okay. So especially focused on type 2 diabetes, where essentially our body cannot produce insulin properly. And then complications, insulin is important to do glucose control in the blood. And if my blood glucose is not controlled, either it's too high or too low, it causes long-term problems. And the long-term problems are quite serious. Blindness, heart diseases, stroke, so on and so forth, right? So there's and type 2 is also the more common version of the disease. Type 1 is genetic, often at birth people will have it. Type 2 is what we develop over time, generally in older ages. Okay. Now the problem with diabetes is affected, my glucose control is affected by what food I eat, how much exercise I do, what stress and sleep levels I have. And generally, if I get diagnosed with type 2, I would essentially get things like these, bunch of pamphlets, they learn about your body, and there might be a combination of general advice on how to manage your diet and medication, okay? And the thing is that there is actually a complex biobehavioral interplay happening. So the blue boxes in this picture are behaviors I do, and activity around meal, what types of meal I have, what's my physical activity during the day, what my sleep cycle is. And the white boxes inside that left big box are all the ways my biology get affected by my behaviors, right? So what's my glucose response to meal? What is my overall glycemic regulation, which depends on how much baseline glucose I have. So body is a non-linear system, so these relationships are actually not linear or easy relationships. And they are different for everyone else. And how do I actually track type 2 diabetes status? Is through a marker called hemoglobin A1C, also shortened for HbA1c. And every 3 months, this actually measures what's your glycation on red blood cells. And that glycation is like an integral over 3-month point of glucose on my red blood cells, because they are the carrier of glucose. Okay, so A1C changes slowly. It's approximately 3-month change, and that's essentially 3 months is the lifetime of red blood cells. That's why generally we measure A1C every 3 months. Okay, and the challenge if I'm diagnosed with diabetes is that I'm making these blue decisions every day, many times a day, but my diabetes status depends on what happens every 3 months. And that relationship is very difficult for people to appreciate. Even I don't know what should I do on a regular basis so that my A1C will go down, other than broad directions, right? So we have to understand, we have to build strong biobehavioral markers, but most of the healthcare settings, especially and when this comes to personalized data, is actually, I would say, still in data scarce regime. So there's a lot of healthcare data is electronic health records data, But if I want a single person's data, generally you don't have enough of it to actually make these things. So we ran a pilot a few years ago with a partner in Santa Barbara, which had 36 participants. So generally pilots tend to be small. This was an underserved Hispanic community. Had people at risk at pre-type 2 and type 2, and we collected tons of data from them. So continuous glucose monitor, activity data. They actually did food logging. So we took that causal diagram and we converted it into measurements we have, right? So we took that diagram and essentially our measurements were trying to fill the boxes of that diagram. Okay. So we get interesting complex data streams like these. On the top is what the glucose monitor is measuring, and you can see the glucose can rise up a lot, often means that I had a big meal. And then, of course, there is exercise which is happening in the bottom, right? So there is, of course, a lot of work. You can apply a lot of very good, powerful data science tools to understand this data. And so there's no dearth of data science tools. Whether we call them data science or AI is your call. But basically, you can essentially analyze it. But at the end of the day, we also want to build things which people can use, I can use in my daily life. I don't want to work with lots of data all the time. So we actually started thinking, what are simple markers, biomarkers, behavioral markers we can come up with, which are also really good from a data science point of view, but also from people use point of view, okay? So we actually came up with a simple idea, which was that we will essentially look at data only around meal events, okay? And then we will divide our meal events into normal and elevated. And that turned out to be really a useful metric to look at least the idea which we were able to convert. What it says is that if I am, let's say, a diabetic, what should be a normal meal look for me? And the normal meal I should aspire to be is one which looks like a pre-type 2 diabetes range. That means I should aspire to be a level below, a level healthier than I am. If I'm pre-diabetic, then I should aspire my glucose response to be closer to what normal people will have, okay? So once we define normal and elevated that way, we found some really interesting results. And this is one of them, which essentially says that if I, let's say, have a glucose A1C which is above normal, then I am allowed essentially one violation a day. That's how you can interpret all this data on this chart. It says, hey, I have one meal which can be a little bit, where I have a glucose response which is a little bit too high, but if I only limit to one such event per day, overall my A1C will slowly go down, okay? So it gives me, if I had a bad breakfast of sort, like big breakfast, then for the next 2 meals I should try to control my other part. If I had a small breakfast and a big lunch, then maybe I should come back down in how much of a dinner I have, okay? Second, we found that the advice we give out walk during the daytime to be actually not very useful. Actually, we found that total daily step count is not a good behavioral marker. It has a very, very weak relationship with the time in range or the marker which we care about. By the way, one thing I want to talk about is how are these results coming about? This is actually an observational trial, but we are getting causal data from it. So there is not an A-B trial. So what we are doing is using really well-developed tool in statistics on getting causal inference from observational data, because we have an understanding of what biological factors affect what, okay? So that's why we can make causal relationships and causal claims in this, even though it was an observational cohort. Okay, so we found step count is not very well correlated with behavioral marker, but post-meal step count, I eat something and go for a walk, is actually a strong behavioral marker, okay? And in fact, this is the thing I've been hoping we will have one day. It tells you exactly how many steps. It says 1,000 steps are actually that threshold, which is very useful for most people. So walk at least 1,000 steps after a meal is the bare minimum you need to get a controlled, well-controlled glycemic response, okay? We had a few more such things, but I want to talk about what do we do such results? There are tons of papers which are data science papers. We did this, we found this. How do you build a product around it? And that's actually the tricky part. And I'd say most of the data science is having or AI, whatever you want to call it, is having a difficult time translating into products. Okay, and especially if you're talking about behavior change products, like things about behavior. So after trying a few things, we now found a way of getting into it. And so we are now partnering with Sutter Health, which is the third biggest healthcare system in California. And they have what is called a metabolic wellness program. And this type of programs are now many healthcare systems are offering. So you can think of them as education programs where they teach you, and you don't have to be diabetic, anybody can take it, these programs. And the idea is that you are taught how to do a little small experiments on yourself through your food, diet, and other things, and exercise, and understand what's happening with your body. The key thing in these programs is that they are sensor-based. In this case, if you want, they will ship you a continuous glucose monitor, and you can use this continuous glucose monitor to see what's happening with your body as you take different actions. So the idea is that they are trying to empower people to run their own little experiments to understand what's happening with their body if they do something, and then build these causal relationships and understanding. Okay. Dr. Ron Sinha had built this program. There were approximately 2 years of running this program and optimizing it. We worked with them, so now continuous glucose monitors are part of that program. And then we just recently finished our first research study. So we took the recent cohort, every cohort has around 400 people. This program is largely online and self-paced. And we built a cohort, we recruited 100 out of those 400 people to run a more deeper research study on them. So this is the research protocol looks like. They answer certain questions. They get 8 weeks worth of CGM, which is 4 CGMs. And then they have the questions afterwards. So we actually can now measure how well this program is working and for whom. And so this is a little bit busy chart, so I'll just give you the punchline. There are different metrics which are used to understand how well somebody's diabetes is in control. They're called time in tight range, which is the range in which you want your glucose to stay in for healthy outcomes, or average glucose, or glucose variability, or something which is accepted in literature is called GMI, which is glucose management indicator. And what these charts, all of them essentially tell the same story, that people who need it the most, the program is working the best for them. So that's actually a big win for this program. They had a poor starting glucose, showed the greatest improvement. So in most of these cases, big bars are good, or other than glycemic variability. And then the glucose variability essentially improves, which is you also don't want your glucose to fluctuate too much, is also improving in every group. In this kind of things, because you're asking people to do behavior change, you have to understand what's the acceptance level. So questionnaires are very important. So we ask them how are they engaging with the program, which program element they find useful. You can see broadly, most of the people are finding at least one program element useful. So either they like webinars, or they may like short videos, or they may like something else. And then if you include CGM, nearly 100% of the people are engaging with the program. And in fact, even better percentage are taken the part of the program and done some changes with their lifestyle. Okay. And probably the most interesting thing from a tech point of view is this chart. It's one of the most boring looking charts in my slides. Is the leftmost bar, the red bar, is the improvement one gets if you engage with all the elements, you listen to all the lectures and so on and so forth, and of course use continuous glucose monitor, which is a sensor. And then the yellow chart is you ignore practically all the lectures, but just look at what your sensor is telling you. Okay, and what shows is almost an equivalence of outcomes. You can just look at your own data, make some accommodations, and if you actually pay attention to it, just that single mode is almost as effective as using the sensor plus all the other things which you learn from the doctor. And that has a huge implication from a healthcare point of view, right? In the sense it's telling you, if I actually send this sensor, and if you engage with this sensor, you have a huge benefit. And that is highly scalable. Just so that for folks' benefit, continuous glucose monitors are now available over the counter. And that means I can walk into CVS, I don't need a prescription, I can buy it, I can put it on, and if I pay attention to my data, I can learn a lot about my body. Okay. So that's a really important outcome for scaling. So where are we going next? Sutter is about to scale this to all their employees first, which is around 12,000 people. So as an employee benefit, now they can actually get a sensor, and then if that works out, then they plan to scale it all to their whole patient population, which is around 3.5 million patients. So this is an example of partnerships which will keep coming up, is really crucial in healthcare. In healthcare, there are very few direct-to-consumer pathways. Most pathways are through providers or payers. So one has to work with these partners so that you can scale. Okay, so this is the last slide on my diabetes picture. Is the idea being that we have started by trying to understand behavior-biology connection, where it was a problem was really relatively well defined, and then we've slowly built a product which is, here the product is actually a program which teaches you about your body, and that product is scaling is happening through a healthcare system. So we are also working with some of the folks now in Houston to see whether we can bring the same idea to other Houston systems in this case. Okay, and in my rapid fire approach, I will move to yet another different area, which is mental health. And mental health, fortunately or unfortunately, got a lot of attention in last few years, but it's also one of the highest rates of illnesses, broadly speaking, the mental health, right? 1 billion people, which is a very large percentage, suffer from some form of mental illness. 1 in 5 in US will have it, and then 1 in 25 live with a chronic illness. That means they will have something which may last their whole lifetime. Okay. And just out of the, for a stat, like depression is one of the most common form of the mental illness, but it's also the most curable version of the mental illness. So nearly 90% of adults will have one depressive event in their life, but most of them get out of it. Okay, so it's in that sense, it's actually good to know that everybody will have a bad time, horrible time in their life, but most people get out of it. So in mental health, there is a huge, the whole of mental health is study of human behavior and its impact. So here are some examples. Sociability deficits, for example, my ability to interact with the rest of the world causes a high risk of psychiatric condition. Impulsive behaviors cause a huge risk of what is called self-harm, or substance use disorder, and so forth. The problem is when mental health, what we don't know, and is the only area in healthcare where we have essentially zero understanding of biological basis of this illness. In fact, this is how all psychiatry is practiced. Psychiatry is based on what is called DSM-5. What is DSM-5? Is only based on self-reported symptoms and physician observation. So essentially, you look at these symptoms. This is basically a clustering mechanism. You cluster them. That's actually how DSM-5 is arrived at, by the way. And you call these different clusters different names. And then we try to essentially take a group of symptoms and essentially use them as a way to define a disease. Imagine if that's how we were doing it for rest of the diseases, we'll be essentially in 1700s, and this is where psychiatry is. Till 1700s, there was no understanding of biological basis for any disease. And as a result, we only used to define diseases by only their symptoms, right? There are just tons of problems. I mean, amazing number of papers published. Everybody is self-aware that they have this problem. So NIH and other agencies have been trying to build what we call a dimensional approach to psychiatry. It's a really, really slow process, but the idea is to essentially adopt what we do rest of the medicine. In rest of the medicine, we have a notion of biomarkers we try to understand, and we try to understand causes, a mechanistic understanding of disease. Okay. So by the way, this whole thing of a dimensional approach to psychiatry is still in the domain of science. There are hardly any big breakthroughs yet, in my opinion. However, you can see people coming up how immune system dysregulation causes mental health problems, how gut health dysregulation can cause also mental disorders. So these relationships are slowly coming around where we are understanding how biology, psychiatry, or behavior a relationship happens. So as I said, my focus was on measuring behavior, so we have been trying to measure different types of behavior. Mobility is easy to measure. Your smartphone and watches can do it. But what we've been doing are things like sociability, which is my innate nature to interact and work with people, and things like impulsivity, which are implicated in substance use disorder. So I'll only talk about sociability, and then our idea was, how do I measure what I call in-person social network? Today I'm in a workshop, I'm going to meet many people, I'm going to have many conversations. Tomorrow I'm actually visiting another place, I'm going to have another set of conversation. Then I talk to my family, my friends, and some people in coffee shop. These are all my social interactions. How do I form what I call my in-person social network? Not the Facebook version, not the LinkedIn version, my in-person post. And turns out that's actually really important for us to understand, has a direct impact on our mental well-being. So we tried a simple idea many years ago where we essentially said we will use egocentric audio. Imagine your wristwatch essentially listening to everything, but not analyzing content, only trying to get conversational information from it. It turns out to be a very difficult problem from a machine learning point of view. If you have multiple speakers, how do you disambiguate them, all those other things. And then you also have no prior knowledge on speakers. Who are these speakers, what their voices sound like, so on and so forth. In any case, we ended up building something we called EcoNet, used a fair bit of existing literature in speech processing. We had to do a few blocks where we had to innovate, and we built out a whole pipeline. Okay, so that part was really fun to do. And then we got to work again with a partner, in this case, Dr. Nidal Mukadam. And then we had a hypothesis. Our hypothesis was, if we have these groups, 3 groups, healthy participants, participant with depression, and participant with psychosis, we will see a visible difference in their sociability. Okay, the hypothesis was that healthy people will have more socialization, depressed people will have less, and people with psychosis who suffer from paranoia would have even less socialization. And so measuring these 3 groups, we will be able to see some differences. And they wore audio band for 12 hours a day for a week. We had recordings over multiple days. And then we got a bunch of this data. And so as an interesting challenge for this data, we were not allowed, our IRB and our protocol does not allow us to listen to the data. Okay, so completely, we never got to hear what they're saying, what they're talking about. We only can actually analyze it with no content analysis. Okay, and that's what the EcoNet thing we built does. So some results were actually affected, were actually something we understood. So PHQ-9, which is the x-axis, which is measures the depression severity. Higher number means higher severity. 27 is the maximum on that scale. And y-axis is the average conversational network size every day. How many unique people I talk to for a certain amount of time every day. Okay. So you can see some negative correlation. By the way, in behavioral sciences, if you go above a correlation of 0.3 or 0.35, that's really significant. Okay, so generally, single variable correlations haven't turned out to be that strong. In this case, you can see is minus 0.56. So that was a significant, it's a very significant correlation, which can actually association. We found something new also. So we found that for people who, if you only look at dyadic interactions, that means one-on-one interactions, they have an interesting relationship. And so we have, as your PHQ-9 changes, and by the way, this below 10 is normal. Like all of us will fall somewhere on the 0 to 10 scale if you don't have clinical depression. And this actually shows positive trend, and it was published actually in a literature. But what we found is that people go into territories that dyadic interactions increases. And actually that's what is called the social isolation hypothesis, that I get more and more depressed, I talk to fewer people, and which is, you can all relate to, is actually true. We actually see that in our data. Okay, so there were other tons of results which came out of this. And so what are we doing these days? And I said, what do we do with this finding? We have to convert it into something practical. And that's where our current big challenge is. Okay. So unfortunately, mental health is an area where every healthcare system spends the least amount of energy. In fact, the average spend if you just average all over the world, like 7, 8 billion people, is only $1 per person, less than $1 per person. It's like the least spent is mental health. It's talked the most, it actually has the least amount of actual investment in it. Okay, so what we are doing these days is to actually work across multiple conditions. Mental health problems happen often when people have other diseases. So we are now working with folks who may have cancer or Parkinson, which is what we're working on these days, or other chronic conditions. And grief, if let's say somebody's loved one passes away, that's when actually a significant number of mental health events happen. Okay. So I wouldn't say where we are. We are doing quite a few things. Again, maybe in a year or two when I come back, I will have more to report. But I thought I'll take the last few minutes, I'm assuming I have a little bit more time, to just quickly talk about how I got into it. By the way, other area I work is wireless communications. It's got nothing to do with health. So it's like a total, I look like I just stumbled into this, and essentially that's kind of what really happened. So I started to explore health because we are across, this is Rice University, and that's medical center. By the way, and that's downtown, actual downtown, and our medical center, which scans now miles deep on this side, has 52 different medical organizations, 4 massive big systems which we can work with, right? So I got really started talking to it, and then as I said, I got interested in behavior, and that became the central thing for research. So that was just my part of it. Being I guess the oldest faculty to start doing it, over the years I got lucky. I started to work with other faculty at Rice, but got to build something also. So here is a timeline when I started out. Ashok Veeraraghavan, who's our current chair, was one of the faculty who does imaging, and I called him before he joined Rice. I said, I have some interesting projects, would you like working with me? He says, sure, and then we did so many things together and still work together very closely. Cognita Labs, what I talked about, was 2013 spin-off, and in these 4 years, we did quite a bit of work, ended up with 2 very large grants, an ERC, which is still ongoing, and Expeditions, which was just finished, and Lynn was part of it, so lots of stories there. And then another faculty, Akane Sano, joined. 2019, Ashok spun off one of the companies from the Expeditions, and 2019 I also became department chair, so I got to campaign to increase the department size, and that's where we got to digital health initiative at Rice was launched. We got multiple faculty lines, space, and so on and so forth. As we go forward, we have essentially now around 20 faculty, and we have just started building a new joint institute with Methodist, which I'll talk in a second, but that's an example of type of partnerships we need on more front end, not only on the back end. So this is how the group of faculty in Rice Digital Health look like. As you can see, only 3 full professors here. All of the 3 professors are either chairs or have been chairs, 4 associates, and most of our faculty are young. It's a lot of young blood. We cover 4 different departments right now. 2 of them are joint with Baylor. We are lucky we have now all the labs set up. And then one of the newer faculty is working on AR, VR, so we have a new lab which is joined with Methodist, and lots of other state-of-the-art facilities, what you would expect in a research active school. What's most interesting is we have a huge number of collaborations across even with this group of people. So many of them are, of course, in Houston. Sutter Health is in California. And the one which I wanted to just quickly highlight is this new institute we are building up, which took me around 18 months to work with Methodist. And last December it was approved, and as of January 1 this year, we are in business, right? And what we're trying to do is, Methodist is a really good hospital system, has a very good rapid digital adoption strategy, okay? And so as I talked about, adoption is one of the hardest part in healthcare, not FDA, by the way. And that's one they have figured out. So the thought process being that if we can take this innovation flow all the way to products and everything, but have a direct partnership where you can actually work with a healthcare system which is very proactive in digital adoption, we can cut a few years in your adoption cycle. That's basically one of the premise or hypothesis for doing this, whether we think that's possible to do. And our focus is, of course, a lot on AI, but also on digital medical devices. So among those 20 faculty, people build new measurement systems, bioelectronics, imaging, and mechanical systems, but also interventional system. If you think about it, a pacemaker is actually a completely electronic device. It's an interventional system. What else Methodist offers us? Methodist has actually worked quite a bit. They have built an EMR digital twin for research. So they've taken their working EMR and built a whole image, live image of it, which updates every week. And now we are integrating all their imaging with it. So that would be, we are actually on our way to it. And the idea is once you actually take all this data together, this is around more than 2 million patients already, which will be scaled up to nearly all their healthcare system. You can just do some amazing things with it. And this is a live data, so it's like you can query it to extract anything out of it, which is huge for research. So that retrospective data, similarly, they have few years ago, they had adopted a system called SickPay. It's medical informatics. It's actually a Houston company where every sensor and every interventional device data from ICU beds is streamed live. And this is how actually the interventionists actually look at their data. And the beautiful part of this is not just a huge amount of data. This system is built like an app store. You can actually deploy algorithms just like you would deploy in an app store on top of this data. And that's hugely beneficial for taking things and building them and scaling them. So we'll have also, the institute will have also access to this, and so do innovators. If you want to work on an ICU algorithm which you want to deploy, there is a business model, there is a deployment model, which is very, very rare to have in most healthcare systems. So we are only 6 months into it, so we have a lot to do on the institute. And there is already a lot of action happening, which I did not include here, but I wanted to just quickly close. Engineering, by the way, has always been working with healthcare. If you think about, if you walk into a hospital, most things are actually engineering innovation, right? All the imaging you do is all engineering innovation combined with basic sciences. And similarly, every drug has a bioscience, bioengineering background to it, or chemical engineering background to it, right? But what's happening is that mostly in healthcare systems are developing these partnerships. So we are not the only one. There are other partnerships. And they are recognizing that instead of just being a wait-and-see type of a consumer, they want to be an active participant in innovation process. And that's a good thing for us. It will actually shave off years for some of the innovations to make. In fact, huge number of FDA-approved products never actually get adopted. They have crossed all the hurdles, but they don't get adopted because of this last adoption bottleneck. And of course, from a personal point of view, I am just enjoying working in an area which is an intersection area, is engineering plus behavior. So I get to talk to my behavioral science colleagues and say all the mean things because now I work in that area to them. So that's the fun part, learning something new every day. Okay, with that, I will stop, and I'm happy to take any questions.
Hello, thank you for the great talk. My name is Federico Cifuentes Urtubey from the University of Illinois, and I have an interest in pursuing research in digital health, so I'm wrapping up my PhD soon, hoping to go into this field as well. So my question is, given all these systems that you've worked on, and it's amazing that you've been able to deploy this all, but the main question is, since we are trying to advance these systems with AI and ML algorithms, a lot of that requires a lot of data, right? So I know in healthcare settings, medical records actually are a rich source of data. So as these systems were being built and developed and iterated on, were those medical records a source that you kind of added onto the system for? So for example, were there features in those records that you were able to improve the system for certain patients?
Oh, I see. So you say, so it's not just learning part, it's changing the records to get better part. Is
Yes.
that what you're asking?
Yes.
So that's actually a continuous process is happening. So in one way, one very simple way it happens every day is that anytime a new drug is introduced, it gets added to a medical record. But the other interesting ways is happening right now is, and so there is a system called ambient AI, by the way. What is ambient AI does today is actually Epic is pushing for it these days. Epic is a healthcare system provider or EMR provider, which is 70% of the hospital systems use Epic. Where it is a microphone sitting in a doctor's office. If I have a conversation, it takes all that conversation and converts it into doctor's notes. And that is getting attached into those EMRs. Now, whether they are doing a good job or not remains to be seen, but that's already happening in this case. The other part of the thing which EMRs are getting enhanced, and I have not been directly involved in it, it's very hard for us to do it from outside, that's why you need insiders to do it, is these sensor streaming data. So currently, for example, continuous glucose monitor sends streaming data, that doesn't show up in EMRs, only reports show up. And that part still remains to be seen, and I think none of the healthcare systems are convinced that they want to build it. So I don't think I'm answering your question, by the way, so I'm sorry.
No, it's still interesting. I think it's important to integrate what you can, right?
One thing I will say, EMRs are a good source of data, but EMRs are extremely noisy.
That's true.
They are,
and there's a lot of missing data too, right?
There's just tons of errors. So it's like, if you just train directly on EMR, you will learn good things and bad things, essentially. And you wouldn't be able to tell the difference between the two. That's actually the biggest problem with EMRs.
Oh, wow.
Yeah.
All right, thank you.
Yeah.
Okay, thank you so much for the very interesting and inspiring talk. This is Leming from Hong Kong PolyU, and I have a question. So that there are so many diseases, and how did you choose one disease and with one medical device and find one practical problem? Yeah, I'm very confused. So could you please share some of your experiences? Yeah.
So I defined my journey mostly as a Brownian motion in medical center, right? So I essentially got introduced to person X, and then I went and just chit-chatted with them. I just would ask questions. I had nothing to offer at that time on my day one, because I was not working in the area. I would say I had no religion of sort, essentially. So I'll just go listen to them. They will tell me 50 problems. I was not interested in 49 of them. Then maybe one will I'm interested, I'll read up about it. So, and then I did that over almost every area, and as many people were ready to talk to me. What I did was, I started this a little bit later in my career, so I already knew how to do research. So that was helpful. And one thing which helped me a lot was that I have traditionally always worked with undergraduate students for research. So I started tons of undergraduate research projects with the students. And they all worked in different areas. And within 6 months, we would have learned something more about something. And I would either know that I would want to continue or not continue. And that allowed me a way, that also trained me and our group as to how do we even pick projects. Now, whether what I learned is transferable, I'm not so sure. I think I figured out a formula that works for me. But essentially, I would say if there were few principles I learned, I listen more than I talk. I ask a lot of questions. And then I would generally look for a piece which is unique. Okay, so I found I don't want to be in the improvement game. I don't want to improve things. I want to be in the invention game. And that means I have learned to say I won't work on it. More often than I say I'll work on something. And that is something which I think, because I had another experience of doing research before, I think I became better and better at guessing where I can do invention, not improvement. So that's why you probably don't see in most of my talks, I will say, here is a device, and it does X, and I will do 10% better than that. I almost never got into that game. So.
Okay, thank you so much.
All right, so I thank you, Ashu, for a very informative and exciting talk. I have two questions. One is, in one of your slides, you mentioned very briefly about a lot of your device, some of your device get FDA approved. I'm sure that's not a very easy process. So can you kind of explain what are the pain points, some of the important pain points during the process of getting those things approved, and also if is there anything, if you're going to restart and do another application for a new FDA approved device, what would be the different direction that you're going to take? Right? So that would be the first question. The second question is that, so Digital health and wireless, they are totally two different areas. And I think one of the biggest problems I can see, and also from my own experience, is the context switching. So you're working on the research direction where you have to basically close the door, focus on a very little detail, the circuitry, the firmware, the software. And then you move to another direction where you have to talk to people, you have to identify the new problems. So can you talk a little bit about what are the excitement about working in that setting, and also what are so not fun about doing so? Yeah, thank you.
I will try. So the first one, I think maybe slightly easier, I would say, when we started, everybody would say FDA, is this process, FDA. In fact, most people talk about FDA as if it is a hurdle. Actually, FDA turned out to is very helpful organization, at least till last year. I don't know about now, but so what you do is, FDA is actually full of real experts. And FDA is mostly only concerned about two things: patient safety and device drug labeling, right? And so they don't actually worry about whether this thing efficacy or not, but they want that if certain safety measures have to be there in anything you do, and if there is ways, let's say this drug cannot be used for children below 4, it has to be on the label. So labeling, they pay a lot of attention. Now, how do you get to that point? You have to run a trial of some sort for anyone to find that what kind of side effects one can have and so on and so forth, what are the risks to patient. And they will actually exactly tell you. So they actually offer meetings. You go into meeting, they will bring real subject matter experts. They're not bureaucrats, they are real subject. They understand inhalers, they understand lungs, they understand this. And those subject matter experts would tell you precisely, work with you, understand it, ask questions, and tell you precisely what trial to conduct. And they generally recommend the minimum possible you need to meet that bar, not the maximum possible. The maximum possible is 8 billion people, you can't do that, right? So FDA we found to be extremely helpful organization. The key is to engage with them. And you have to engage with them, you have to reach out to them, and they have a process to engagement. And we didn't find actually a problem with them. So I would say FDA is an easy part of the thing. It doesn't scare me at all. I think I found them as a partner in this whole thing. The other thing is that our devices are not very invasive. So they are very low, class 1 devices. So class 1 devices are actually much lower bar. Class 3 devices, which are drugs, they tend to have a much higher bar for them, or surgical devices and stuff like that, right? You can imagine they need to have a higher bar for those. The second question about, I hope I answered that enough. And second question about working on 2 areas, I don't know what to tell you. I just started doing it. I was interested in it. I would say, everybody says when you become tenured, you have a lot of freedom. I used it maximally. And I had the maximalist use of that. I just went from area to area, and many of my colleagues do it too, but I went into an area which is very opposite of what I do. And I think the biggest difference is thinking differently. When we work in wireless or mobile systems or whatever, we are the boss of what we will choose to do. When you work in healthcare system, I cannot cook up problems. I mean, I can cook up problems and work on it, but I didn't want to do that. So then you are no longer the boss. You can only collaborate with people. And that was, I think, the biggest mind shift I had to do. Fortunately, I was ready for it. I knew that most papers in healthcare don't become products. So I remember having conversations with my colleagues early on. I said, my end game will be products, not publications. Publications are important. Students have to get PhDs and stuff like that. But my end game, I will measure my success by products. And that has been the driver force for me to say, how will I spin out something? Now, I haven't been successful all the time. I only told you some cases. In mental health, I may never be successful. But that was my day one. It has to be a product, and likely I will have to build it out myself, because nobody reads a paper and builds one in healthcare, broadly speaking. But again, I'm not sure whether I'm answering. It's just, I think many of us are curious people. I took my curiosity to the next level, I will say. So.
Thank you so much. Any other question? Let's thank Ashu one more time.